Morena, welcome back to our Mahi Atua page, Dr. Di's readings. My name's Dr. Diana Kopua. I'm a psychiatrist and I'm here really enjoying reading a book from Joanna Moncrief, a critical psychiatrist who belongs to the Critical Psychiatry Network. This is one of her books. We're up to chapter 3 and I'm going to carry on reading. I just started the live on our personal page, so I've just take 2 on that. And for those of you tuned in, I'll keep this post up so I can see any comments you have. Aloha mai. Last time there was a question, so I did write in it. If you're looking to come off psychotropic drugs, one of the key things that I recommend is that you do it with the person that prescribed those drugs to you. If they're not available, then reach out to your GP and have that discussion with your GP. Now, the advice that the GP gets is usually in consultation with a psychiatrist, so it's important that you know who the psychiatrist is that is advising the GP, and depending on not just their philosophy, but also whether they're up to date with the research, will impact the advice given to the GP. So I really do encourage you to make sure that you go in with a strong support network if you're looking to come off your medication, or at least reduce them down to even just one medication or reduce the dose. You know, in medicine it is useful to know that we prescribe medication to have the most therapeutic effect on the most minimal dose. And many of you, when your medication isn't working or there are adverse reactions, you are prescribed more medication on top of what you're getting. How do I know that? Because I'm also working for the Hauraki PHO, and many of the requests from GPs highlight that you in the community are on many medications. So please do it with your whānau, your network, in support of this change. If they're not in support, it's usually because they fear you becoming unwell again. So it is advisable that you all get informed together. Knowledge is very powerful. Chapter 3 we're up to, the importance of research. Understanding the implications of research into psychiatric drugs is complicated, not least because the nature of the complaints for which they are prescribed is contested. Belongs to the Critical Psychiatry Network. This is one. Nice. Morena Pauline. There is no general agreement about what mental disorder or mental illness consists of, or how we should understand or research. However, when we do something to the body, such as administer a drug, we need to work out what effects it has and how these effects might impact on us. In other words, we need to know how a drug changes the way our body functions and all the consequences this has for us. In the case of psychoactive or brain-modifying drugs, we also want to know how the drugs change our thoughts and feelings, including those that are unusual or unwanted, such as the symptoms of mental disorders. Then we need to know how these modifications affect our day-to-day lives. Existing research is hard to interpret, for all the reasons that I explore below, but that does not mean we can dispense with research altogether. Properly conducted research is vital to protect us from the enthusiastic promotion of hypothetical remedies that turn out to be ineffective or even harmful, which has happened throughout the history of medicine and psychiatry. For centuries, doctors recommended bleeding for the treatment of numerous complaints. Not only was it ineffective, it was often actively harmful and almost certainly killed many people. In the 20th century, a procedure called Insulin Coma therapy was widely thought to be an effective treatment for people with schizophrenia. As the name implies, it involved putting people into a dangerous coma using insulin, and it was enthusiastically administered in hospitals throughout the world. There was no clear theory about how it might work. Some psychiatrists proposed it corrected an underlying hormonal abnormality, others that it produced a physiological lobotomy that worked by destroying malfunctioning brain tissue. When a randomized trial was eventually conducted in the 1950s, insulin coma therapy turned out to be more effective than giving someone a general anesthetic. Since insulin coma therapy was a dangerous procedure with a significant mortality rate, many people died because this therapeutic enthusiasm was not subjected to rigorous research earlier on. Interpreting research on psychiatric drugs. In subsequent chapters, I will summarize some of the large amount of research into the effects of different classes of psychiatric drugs. When looking at this research, it's important to be mindful of its limitations and biases. First, psychiatric drug research uses the methods that are applied to the study of treatments for physical diseases. However, as we saw in Chapter 1, many people have challenged the validity of treating mental health problems as if they are medical or physical conditions. Viewing a mental disorder as a medical disease or condition suggests that it can be identified, quantified, and measured independently of the person who is experiencing the problem. This is the way that we think about cancer of the liver, heart disease, or arthritis, for example. We can measure the features of those conditions fairly easily because they are physical things that we can see and touch. They have a characteristic appearance and they progress in characteristic ways. Diseases of the body have similar features in all the people who have them. By measuring non-physical things like emotional experiences, beliefs and behaviour is, many argue, inherently different. This is reflected in the fact that it is more difficult for people to agree on what they think about them. For example, how do we decide whether person X is sadder or more depressed than person Y? One observer may feel that X's behaviours and statements indicate greater sadness, but another may believe that it is Y who shows the deepest depression. It is difficult to understand emotional states, thoughts, and behaviours as abstract entities. They always belong to an individual person, and their meaning depends on the particular circumstances of that person. We cannot understand the nature of thoughts, emotions, and behaviours if we try to think of them in isolation from the people who experience them and their individual situations. Sadness, happiness, depression, anxiety, and paranoia, for example, are not things that can be weighed and measured in their own right. There is always a person who is sad, happy, depressed, anxious, or paranoid, and to understand these states and feelings, we need to understand the situation of the individual concerned. What this all means is that measuring the expressions of mental disorders as if they were the symptoms of a physical disease is not necessarily helpful. It does not tell us about the real nature of a person's problems in the same way that medical tests reveal information about the state of a person's body. Emotional states and behaviours cannot be described and quantified in the same way that we measure the properties of physical objects or biological tissues. Therefore, when measuring scales and scores are used to describe mental states in psychiatric research, it is not clear what they really mean. There is also a lack of research that looks at more tangible indicators of how someone is doing in their life, such as whether they are employed or their use of health services. Second, as mentioned in Chapter 2, research involving psychiatric drugs is conducted and interpreted on the assumption that the disease-centered model of drug action is correct. Since this model was adopted in the 1960s, it has barely been questioned. Indeed, it is so well accepted that most mental health professionals and researchers are not even aware that there are other ways of considering the effects of psychiatric drugs. Therefore, most research does not describe or account for the sort of mental and behavioural alterations that psychiatric drugs produce in general, or how they might modify the feelings and behaviours that are associated with a particular diagnosis. Instead, research studies simply assume that drugs reverse an underlying disease process and attempt to measure the symptoms of the disease, even though the mental and behavioural alterations produced by some psychiatric drugs such as antipsychotics, benzodiazepines and stimulants are striking and undeniable, as described in the following chapters. The impact of these alterations on symptoms is ignored and interpreted as a change in the underlying condition. If drug-induced alterations are described at all, they are referred to as side effects, such as drowsiness, which are not acknowledged as having an impact on the symptoms or disorder. Side effects are considered to be an incidental nuisance of no fundamental importance to the action of the drug. They are listed briefly and relegated to the end of research papers or documents such as drug information leaflets. Third, research is highly influenced by groups whose interests are best served by overstating the benefits of drugs. The psychiatric profession and pharmaceutical industry conduct and publish most research on drug treatments. Both these institutions have reasons to underplay the adverse effects of drugs, overstate their benefits, and promote a disease-centered model of drug action. An example of how these drugs can influence research is what is known as publication bias. This refers to the finding that studies that find positive effects of drugs are more likely to be published in academic journals than studies that find no effects or harmful effects. If studies are not published, most psychiatrists and researchers will not be aware of them. The manner in which studies are published can also present drugs in a more beneficial light than the data justify. Researchers in the US, for example, found that 51% of studies submitted to the drug companies of the US regulatory authority, the Food and Drug Administration, FDA, between 1987 and 2004, demonstrated that antidepressants were superior to placebo. Yet 94% of trials published in scientific journals in the same period appeared to show this. Trials found that antidepressants were no more effective or worse than placebo, were less likely to be republished. Hang on, I'll do that again. Trials that found that antidepressants were no more effective or worse than placebo were less likely to be published, or were published in a way that made the antidepressant appear to be more effective than the placebo, even though it was not. The pharmaceutical industry has a clear vested interest in overstating the benefits of their products, but doctors, researchers and editors have also played a part in focusing on research that highlights the positive and plays down the negative effects of drugs. That's our reading for today, whānau. So the publication bias is huge. I think we need to pay attention to it. As you heard, from 86 to mid-2000s, publications on antidepressants where they weren't shown to be any more effective than placebo, or in fact worse, we're less likely to be published. Not the one. Kia ora everyone. Kia ora. Barry, no, I'm not referring to the COVID vaccination. I am very specific with psychotropic medication, and I don't really want to have a discussion about that because although I do agree that publication bias can impact everywhere, my area of expertise and my support in this is huge, and so I'm going to restrict it there and make no comment about what you say. And I'm not even sure if I disagree with you or agree with you, so I make no comment. But I am pro-vaccination for COVID, and I have been vaccinated. I'm keen to hear more about your thoughts about psychotropic medication. I'm keen to hear if you're on antidepressants. I'm keen to hear how the beginning of that story started. Did you show up to a GP and, did they recommend it without any other idea of just holding space and listening to your story so that you can feel heard? Did you get the medication a long time ago and it hasn't been reviewed? That's the sort of stuff that I'm really keen for you to think about. If you're on the medication, have a think about how long you've been on it. Did it work? And if it's working and you've been on it for, say, 3 to 5 years, then, it's not meant to be with you for 3 to 5 years. In fact, there is an absolute need for you to think about slowly discontinuing your medication if you are well. And knowing that when you come off the medication, the withdrawal effects, particularly for those who have been on the medication for a long time, can appear like you're becoming unwell. So take care, everyone. Morning to everyone who's tuned in. It would be really good to respond to any questions over time. You might be able to watch a few of the other readings that we've made about the book, but I'll be back to join you on Monday morning. Ngā mihi, kia pai o koutou rā.